Okay, let us continue. Raise your hand if you're able to hear me clearly. All right, that's good enough. The next chapter we'll be looking at is immunologic emergencies. A lot of the material or information in this chapter, if you studied your shock chapter well, you would have covered majority of immunologic emergencies. Introduction. EMTs often respond to calls involving allergic reactions. Allergy-related emergencies may involve acute airway obstruction and collapse of the cardiovascular system, which is shock. You must be able to treat these life-threatening complications. You must be able to distinguish between the body's usual response to an allergen and an allergic reaction. Immunology is the study of the body's immune system. Let's review the anatomy and physiology. The immune system protects the body from foreign substances and organisms. When a foreign substance invades the body goes on alert. The body initiates a series of responses to inactivate the invader. And during that sequence or series of responses is when the body becomes sensitized. Now, it is possible for a person to have an allergic reaction without sensitization. That is outside the scope of this course. Pathophysiology. An allergic reaction is an exaggerated immune response to any substance, not caused directly by an outside stimulus. It is caused by the body's immune system and the release of chemicals to combat stimulus. And these chemicals include histamines and leukotrienes. When the body produces histamine, histamine causes the air passage to constrict, and it causes the blood vessels to vasodilate or open up, and it causes increased permeability. When leukotrienes are released, which it is released slowly, so it's not as fast as histamine. It's released very slowly, but it is way more potent in its effects than histamine. Way more potent. So when leukotrienes are released, it will cause extreme bronchoconstriction. It will cause the coronary vessels to vasoconstrict, and it causes increased permeability. Some patients may not know what is causing their reaction, so you must recognize the signs and symptoms and maintain a high index of suspicion. An allergic reaction may be mild, and when it's mild, it means it's a localized allergic reaction. So it can be mild, moderate, or severe. Mild means it's localized to a specific area of the body. Moderate means it is moving throughout the body, but the breathing and the cardiac output is not compromised. So the respiratory system and the cardiovascular system is not being significantly affected. That's a moderate reaction. Severe means the respiratory system and the cardiovascular system is being affected by the reaction. Anaphylaxis is an extreme, life-threatening allergic reaction. It involves multiple organ systems and can rapidly result in shock and death. And depending on the area of the body that is affected will dictate the type of signs and symptoms that are present. 3 common signs of anaphylaxis: urticaria or hives, which are small bumps on the skin that itch. So these small areas of generalized itching or burning that appears as multiple small raised areas on the skin. They can have angioedema, which is swelling of the tongue, and this is common with allergic reactions associated with ACE inhibitors, which are a type of blood pressure medication. They can have wheezing and a high-pitched whistling breath on expiration. It can be so extreme that the airway is completely compromised, where they need a surgical airway. You may also note hypotension due to vasodilation and increased capillary permeability. Gastrointestinal dysfunction, example nausea and vomiting, and abdominal cramps may be present as well. Common allergens. You have food, may take more than 30 minutes to appear, example shellfish, nuts. Medication, antibiotics, example penicillin, non-steroidal anti-inflammatory drugs. If medication is injected, so if the medication is injected, the reaction will be immediately severe. Reactions to oral medications may take more than 30 minutes to appear, but can also be very severe. Continuing with common allergens, plants, example dust, pollen, and other plant materials, ragweed, ryegrass, maple, and oak. Chemicals, example makeup, soap, hair dye, latex is of particular concern to healthcare providers. In first world system, the latex gloves are no longer used. The vinyl and nitrile gloves are used more commonly now. Common allergens, continuing with common allergens, insect bites and stings. When an insect bites and injects the bite with its venom, this is called envenomation. The reaction may be localized, can produce swelling and itchiness, or it can be systemic, involving the entire body. Insect stings is approximately 3% of insect stings in approximately 3% of adults and 1% of children are allergic to the venom of bees. What am I saying? Approximately 3% of adults and 1% of children are allergic to venom of bees, wasps, and hornets. The allergic reaction to insect stings and bee stings and hornets, not that common in Jamaica. Definitely common. You'll see that more in the first world, overseas. Not sure what's the reason for that. I know my generation, we used to get sting all the time, a lot, because we spent more time outside than inside. Allergic reactions to insect stings cause at least 50 deaths per year in the United States. The stinging organ of most insects is a small hollow spine projecting from the abdomen. The venom can be injected directly into skin. Honeybees cannot withdraw their stinger They fly away and die. Wasps and hornets can sting multiple times. Some ants, especially the fire ant, strike repeatedly. They inject a particularly irritating toxin at the bite site. Now, signs and symptoms: sudden pain, swelling, localized heat, urticaria or hives, redness in light-skinned individuals, itching, and wheal, an area of swelling. Not significant swelling though. Applying ice sometimes helps. Swelling may be dramatic and frightening. Localized manifestations are not serious. In severe anaphylactic cases, the patient will experience bronchospasm and wheezing. They'll have chest tightness, coughing, dyspnea, anxiety, gastrointestinal complaints, and there will be a drop in the blood pressure. Patients may occasionally experience respiratory failure. Respiratory failure is classified by a decreased level of consciousness and poor chest rise. If untreated, anaphylactic reaction can proceed rapidly to death. Patient assessment in an immunologic emergency. Size up your scene. So scene safety. The patient's environment or recent activity may indicate the source of the reaction, sting or bite. Food allergy, new medication, regimen. These are things you need to be looking out for. Be mindful of other potential causes of respiratory distress. Traumatic injury may also be present. Follow standard precautions with a minimum of gloves and eye protection. Consider the need for additional resources such as advanced life support personnel. In your primary, quickly identify and treat any immediate or potential life threats. Form a general impression of the patient and the environment. May present as respiratory or cardiovascular distress in the form of shock. Patients often appear very anxious. Call for ALS backup if available. Look for medical identification tags. Airway and breathing. Anaphylaxis can cause rapid swelling of the upper airway, and the swelling might not be external. So when you look at them externally, you might not see any swelling, but the swelling is occurring inside the ear passage. You have only a few minutes to assess airway and provide life-saving measures. Work quickly to determine the severity of the symptoms. Quickly assess for increased work of breathing, accessory muscles, head bobbing, which is an ominous sign, tripod positioning, nostril flaring is also ominous, abnormal breath sounds. And if you cannot hear any breath sounds, you need to be concerned about that. Assist the patient into high Fowler's position to maximize ventilation. If signs of shock, place the patient in supine position. Do not hesitate to initiate high flow oxygen. In severe situation, assist using bag valve mask attached to oxygen. In your circulation, may present with hypotension. Palpate for the presence and quality of a radial pulse if the patient is responsive. They are not responsive, carotid. Assess for rapid pulse rate, cool cyanotic or red moist skin, delayed cap refill, especially in your pediatric population. These findings may indicate hypoperfusion. Treatment: oxygen, positioning, recumbent or supine, prevent the loss of body heat. Definitive treatment for anaphylactic shock is epinephrine. Transport decision: always provide prompt transport for any patient who may be having an allergic reaction. Take along the patient's medication. If the patient does not exhibit severe symptoms, consider continuing assessment en route while performing emergency transport. Excuse me. History taking: investigate chief complaint, history of the present illness, identify associated signs and symptoms. This is a nice table to look at, so definitely pay attention to that table that outlines the signs and symptoms for the various systems, especially the respiratory, cardiovascular, and the skin. Sample history: if possible, ask the following questions. Have an intervention already been completed? Has the patient experienced a severe allergic reaction in the past? Be alert for any statements regarding ingestion of foods that cause allergic reaction. Ask about gastrointestinal complaints, nausea, or vomiting. Your secondary assessment: physical examination includes a systemic head-to-toe or focused assessment. Auscultate for abnormal breath sounds, wheezing, or stridor. Inspect the skin for swelling, rashes, or urticaria. Assess your baseline vital signs: pulse, respiratory rate, blood pressure, pupillary response, oxygen saturation. Skin signs may be unreliable. Monitoring device: definitely utilize your pulse oximetry. Can be a useful method to assess the patient's perfusion status. If your service allows or has it available, utilize Untitled CO2 monitoring as well. So the Untitled CO2 monitors ventilation, pulse oximetry monitors oxygenation. Decision to apply oxygen should be based on airway patency, work of breathing, abnormal lung sounds. Reassessment: repeat the primary assessment, reassess the patient's vital signs, and repeat focused physical exam. If patient is unstable, reassess every 5 minutes. If stable, every 15. Deterioration of the patient's condition could be rapid and fatal. Monitor the patient's anxiety level / mental status. Watch for signs of shock. Interventions: determine the severity of the reaction. Mild reactions require supportive care and monitoring. And remember, a mild reaction means that it is localized. Moderate means it is spreading throughout the body, but the respiratory system and the cardiovascular system is not significantly compromised. Severe is your anaphylaxis. That means the respiratory and the cardiovascular system is compromised. So if it's a mild or moderate reaction, DPH is going to be beneficial to the patient. If it is severe, then epi is your first line treatment. The patient will need epi, then they will need an antihistamine, and then they will need a corticosteroid to reduce the risk of further reaction. So it's epi first, then antihistamine, then you consider giving a corticosteroid. And the EMT is only allowed to give epi, full stop. So it's oxygen and epi, full stop. Interventions: Determine the severity of the reaction. Mild reactions require supportive care and monitoring. Anaphylaxis requires epinephrine and ventilatory support. Now, do not neglect ventilatory support to give epi. Right? So if the patient is having ventilatory issues, that need to be addressed while you get your epi ready for administration. Transport to a medical facility, recheck your interventions. Communication and documentation. Documentation should include signs and symptoms, reasons why you chose to provide the care you did, patient's response to the treatment. Now let's look specifically at emergency medical care for immunologic emergencies. If patient appears to be having severe allergic or anaphylactic reaction, administer BLS, ABCs. Provide prompt transport to the hospital. If a stinger is present, scrape the skin with the edge of a sharp, stiff object such as a credit card. Do not use tweezers or forceps to remove the stingers. That can squeeze venom into the area. Wash the area with soap or antiseptic solution. Remove any jewelry from the area. Position the injection site below the level of the heart. Apply ice or cold packs. Do not put ice or cold packs directly on the skin. Wrap them in something, then put it on the area. Be alert for signs of airway swelling and other signs of anaphylaxis. Place the patient in supine position and give oxygen as needed. Monitor the patient's vital signs. And we will only have the patient in the supine position if we need to do aggressive airway management. So if the patient is responsive and communicating with you, keep them in the position of comfort, and usually it's going to be an upright position. They lose consciousness, then you have to work with the patient in the supine position. Epinephrine. Epinephrine mimics the sympathetic fight or flight response. So the epi that we give in EMS is referred to as a sympathomimetic medication. It mimics the sympathetic nervous system. So it will cause the blood vessels to constrict, which is what we want for a patient in anaphylaxis, and it will cause the air passage to open up. Both of these responses will be early and important interventions for a patient in anaphylaxis. So the quicker we can open up their air passage and the quicker we can get the blood circulating, the better their chances of survival. So epi causes the blood vessels to constrict, it reverses vasodilation and hypertension. That's the goal. It increases cardiac contractility and relieves bronchospasm. Rapidly reverses the effects of anaphylaxis. Epinephrine is prescribed by a physician or comes as a pre-dosed EpiPen or epinephrine injector. The EpiPen is no longer utilized in EMS because it's too expensive. So most services now carry the epinephrine in a vial. EMT is required to draw it up in a syringe, 1 ml syringe, and give the injection to the patient intramuscular. Your EMS service may or may not allow you to assist the patient in the administration of epinephrine. Refer to local protocols or consult medical control. So this is your EpiPen. You have one for adult, you have one for pediatric, and it can have more than one dose. The standard dose for your adult patient is 0.3 to 0.5 milligrams IM. So that's the standard dose for adults, 0.3 to 0.5 milligrams. The standard dose for your pediatric patients is 0.15 to 0.3 milligrams IM. That's the standard dose for pediatric patients, 0.15 to 0.3 milligrams IM. For your adult patient, the injection is in the thigh, lateral aspect, mid-region. For your pediatric patient, it's anterior thigh, mid-region. So adults lateral, pediatrics medial. Side effects of epinephrine. Because it mimics the sympathetic nervous system, it's going to cause the blood pressure to go up. So be careful in giving epi to a patient with an elevated blood pressure, because it can cause issues. But you can be guided by your medical director. So the need may outweigh the risk. So it can cause high blood pressure, it can increase the pulse rate, the patient is going to get anxious, it can cause cardiac arrhythmias, can cause pallor, pale skin, dizziness, chest pain, headache, nausea, vomiting. Do not give epinephrine to patients without signs of respiratory compromise or hypertension. So these are your key findings you're looking for. Is the airway compromised? Is the blood pressure low? Those who do not meet the criteria for diagnosis of anaphylaxis. And that is the end of the chapter. It's a very short chapter, and if you covered distributive shock well, which focused on anaphylactic shock, then you pretty much covered this chapter, majority of it. Now let's go to the question. Question 1.